today we have Dr. Darisa Espinal. Dr. Espinal is a naturopathic physician, graduated from the University of Bridgeport, and has done a lot of additional training, a master's in human nutrition, also undergoing the IFMCP education currently and anticipated to finish in 2022. She also works at the Sandy Hook Clinic with Dr. Kara Fitzgerald, and I'm excited that Dr. Espinal is here today because she is highly, highly experienced in functional lab testing. If you know Dr. Fitzgerald, you know that's a big piece of where she comes from and what she does, and this entire clinic is founded on helping people understand their health better through functional testing. So Dr. Espinal, I'll let you go ahead and take the reins.
Thank you. Thank you for that lovely introduction. Very happy to be with you all. All right, so today's topic is environmental toxins and mycotoxin. And as we know, environmental toxin is really an umbrella term. But today I'm mainly focusing on toxic metals, heavy metals, that I feel like are often not talked about or overlooked. So let's get started here. Here we go. So this is kind of a small outline. Toxic metals, we're talking about aluminum, arsenic, cadmium, lead, and mercury. And in the end, I am going to talk about one mycotoxin, abbreviated ZEA, and I think it's very important because it's not something that we think about clinically, and it goes really well with the women's health reproductive piece in a different talk that we're hosting. So overview of toxic metals. What is it? You know, they produce significant oxidative stress. We know this. They create a lot of free radical formation and just metals overall, right? So high levels of iron, chromium, cobalt, even arsenic, when found in the system at high levels, will cause a lot of free radical and oxidative damage. Cell damage, apoptosis, lipid peroxidation is another one that we tend not to think about with the metals. So malondialdehyde is one of the major aldehydes as a byproduct of the lipid peroxidation. It's one of the actual markers that, although we don't see, it is what's tested to kind of give you that lipid peroxidation range that you see in a lot of the functional testing that we do through the bigger labs, you know, Genova, et cetera. And it's quite a reliable marker, and it's very well accepted in the literature that elevated levels is a good indication of, you know, the significance of lipid peroxidation. Obviously, high levels of toxic metals is a carcinogen, a very known neurotoxin, and can cause mitochondrial toxicity. So let's start with our first toxic metal, aluminum. So aluminum is the third most abundant element in the Earth's crust. It's toxic, it's a silvery metal, and it's non-essential. What does that mean? It means it has no known biological function. It is also a very well-known and well-documented neurotoxin. And like many metals, you know, it likes fatty tissues, it likes to deposit within organs inside of cells and kind of harbor there. But there are certain metals that have more specific target tissue. And in the case of aluminum, the brain, the blood, and the bone are what's mainly affected, but it can also be found systemically in all different tissue types and organ systems as well. So negative effects of essential elements, it negatively affects essential elements. So calcium, iron, phosphorus, magnesium, especially magnesium and iron, it tends to displace and cause an array of symptoms. We know magnesium is a cofactor for various hundreds of different enzymes, and iron, obviously, high levels of aluminum displacing iron can cause a form of anemia. 95% of aluminum is bound to plasma protein, albumin, and transferrin, transferrin being where it's mostly bound to. And how do we eliminate aluminum? Mostly through the urine, but it can also be eliminated via stool, sweat, and other munctories like perspiration, etc. So what are some common places where, you know, we think about aluminum exposure in regards to the patient or the client? Antiperspirant deodorant, absolutely number one place, right? And that's kind of self-explanatory. Toothpaste is another area, and cosmetic, especially cosmetics that come from overseas that are not well regulated. We're thinking about possible aluminum exposure. Aluminum cookware, we're getting into the holiday season, so foil roast pans, right? They're very popular in this holiday season, and we want to think about that with aluminum toxicity and maybe some presenting symptoms around the holiday season. Boiling water in an aluminum pan increases concentration of aluminum big time. Other places, infant formula, there's a lot of documentation, infant formula does have some trace amounts of aluminum. Childhood vaccinations, not all of them, but some of them, and baby pureed food. Right now, the FDA is working with some of the major baby pureed food companies because there was some testing and definitely showed higher levels of aluminum, specifically root vegetables, right? Because if it's grown in contaminated soil, and I mean, it's found in the Earth's crust, right? So to be completely aluminum free soil, it's almost impossible, but it's the amount in the root vegetables that tend to suck it up and found in baby food, it's quite alarming, and it's gotten a lot of press these days. So some antacid as well will have aluminum. Caution, antacids also contain talc, which has its own complication. And then you add that there's some talc that's contaminated with, I believe is arsenic. So yeah, so careful with that. Cans, ponds, and pans, great issue. And then contamination found in food, water, soil, and air, you name it, aluminum was found everywhere. Sorry, talc, I meant to say asbestos. Some talc, the way that it's manufactured, kind of dug up, it can have some asbestos. Obviously, that can lead to mesothelioma down the road. So think about that in patients who are chronically taking antacids. So aluminum clinical manifestations. So how do you follow up if you suspect aluminum exposure? One thing you're going to think about is bone, right? So you want to check bone resorption, which we'll get to in a second, and perhaps a DEXA scan, especially for the postmenopausal female. Oxidative stress, right? So working on the oxidative stress, reducing inflammation, targeting some of your everyday comorbidities like diabetes, cardiovascular disease, all those things can, especially increase in adipose tissue, will create oxidative stress and only make matters worse when it comes to toxic metals accumulation in the body. You want to look at that individual's essential elements. So calcium, iron, copper, zinc, vitamin D, right? What are those? Aluminum tends to displace a lot of them, drop those levels down. So you want to make sure they're well within range. And at the end of the presentation, I'll talk about some of the functional lab testing that we order a lot at the Sandy Hook Clinic and some of my personal favorite as well that go in conjunction with toxic element testing. All right, so some associated diseases, it's obviously a neurotoxin. So every person who has Alzheimer's disease, Parkinson's, dementia, ALS, even multiple sclerosis, right, has a large affinity to the brain, that spinal cord, that nervous system, right? So you need to check them for aluminum and other toxic metals, hands down, because most likely than not, they might have some exposure and it should show in labs. Autoimmune disease is another one that's associated with elevated levels of aluminum. Osteoporosis, so high pyridium cross-links, those are markers that when bone is broken down, it elevates. So that's a nice test to kind of run. And high deoxypyranidine indicates increased rate of bone loss. So aside from the DEXA scan, you want to look at these other functional markers and say, hey, okay, we know we have some osteoporosis, probably some osteomalacia, right? Let's look at the rate. Let's look at the rate of breakdown of bone, and then you can start treatment and then reassess to see if those numbers have come down. Obviously, treatment, osteoporosis, exercise, vitamin D, K, calcium, other trace elements, but making sure that their toxic load is low, right? Don't forget that with osteoporotic patients. Then there's chronic kidney disease, renal failure, and dialysis. These patients obviously are very prone to increased toxicity of metals, because they have an inability to excrete these because they have low renal function. And then obviously cancer and pulmonary disease. So some symptoms of aluminum toxicity. So this is true toxicity, anywhere from myoclonus, speech impairment. Patients in chronic dialysis tend to a side effect can be encephalopathy, clinical manifestations, Alzheimer's disease, Parkinson's, dementia, ALS. All of these neurological or neurodegenerative disease, you want to make sure that you're doing a toxic element panel on them and making sure that one is being assessed and then addressed, right? Actual aluminum toxicity is not that common. However, chronic exposure of aluminum is more common because, again, we're exposed to it every day in our lives. And addressing that to prevent chronic diseases is very important. So some functional testing, there's some functional labs. Total porphyrins plasma is one of them. Blood aluminum, 24-hour urine or random urine. A toxic element report. So you might want to do it with a chelating agent, right? You want to kind of challenge, right? You want to challenge the metals, get it out of the tissue so that you can get a true reading. But for patients, clinicians, for whatever reason, can't do that. What we do at our clinic, we do a glutathione challenge where they take, let's say, liposomal glutathione a couple of days, let's say a week or two before doing a urine or even a blood toxic element report. And that tends to show the true elevations of, whether it's aluminum, arsenic, cadmium, etc. So that's one way to kind of get around it. We kind of do like a glutathione provocation, you could say. High levels of citric acid, isocitric acid, and cis-aconitic acid found in your typical oat test. High levels of that may be caused due to mitochondrial dysfunction. And if you have mitochondrial dysfunction, you want to rule out the possibility of heavy metal toxicity or metal toxicity in general. So what are some management? Selenium opposes aluminum. We know that. Calcium citrate, right, increases intestinal absorption of aluminum. And it's really the citrate that increases intestinal absorption of the aluminum. So our postmenopausal females who are supplementing chronically with calcium citrate, plus they already have increased rate of bone turnover, you want to assess their metals, not just their aluminum, but all their metals to make sure that you're not increasing that absorption rate of aluminum into the system. And obviously caution with patients with chronic kidney disease and renal failure because of their inability to properly detox. So what to avoid? You want to avoid cooking with fluorinated water in an aluminum pot because together, when heated, increases leaching substantially into the water and then into the individual. Cooking acidic foods such as tomatoes in an aluminum pot, again, that acidity only increases the leaching and exposes the individual to high levels of aluminum. So these are the things, it's not just what utensils you're using, but is it being heated? And if it's being heated, are you using things like fluoride or acidic foods that are only going to increase that leaching by a lot more, right? So tips, you want to cook with filtered, defluorinated water. You want to swap aluminum cookware for stainless steel. One thing you should caution or kind of keep in the back of your mind that certain stainless steel cookware may trigger a nickel allergy in certain individuals. These are my references. All right, now let's move on to arsenic. So arsenic, another toxic element, its mechanism of action, it distorts enzymatic protein structures, causing it to lose its function. It binds and inhibits cofactors of alpha keto acid dehydrogenase, and it competes with ATP. So when you're gonna, add that phosphate group into the ADP to create ATP, arsenic kind of competes with that phosphate group, rendering inactive. Therefore, you have less ATP that results into mitochondrial dysfunction. Again, patients who have mitochondrial dysfunction, or you suspect, right, lack of energy, maybe you ran an an organic acid test, and things just don't look quite as right, you want to follow up and make sure that you're ruling out toxic elements as one of the culprits. Um, so there's two main forms of arsenic. There's a toxic versus a less toxic form. Organic arsenic is a less toxic form, and you commonly find that in seafood. And then there's inorganic arsenic. That's what we caution individuals, and that's the toxic kind. And we'll talk about places where we can find inorganic arsenic in the next slide. The EPA cutoff limit is 10 parts per billion of drinking water, and its target tissue is mainly the liver, spleen, kidneys, lungs, and GI tract. But again, like any good element, toxic element, it can really hide in any tissue space. So arsenic exposure. Arsenic is naturally found in the soil. You can most commonly get exposed to arsenic via contaminated water, well water as well, and seawater. Chicken, but not just any part of the chicken. The liver. The liver is highly concentrated with arsenic of the chicken. So careful, you know. I mean, liver is great for certain things. It has a lot of methyl cofactors, but in another spot, you know, it harbors a lot of toxic chemicals like arsenic. Rice, another very common place where you'll find arsenic. And it's actually, surprising enough, higher in brown rice than in white rice because in the brown rice, the arsenic tends to kind of accumulate in the rice bran itself. Careful with babies who are drinking rice-based infant formula because that's only going to increase their arsenic level. And of course, it's a neurotoxin. Babies have underdeveloped blood-brain barrier. And then avoid rice-based milk in early childhood, you know, to reduce that arsenic exposure on that growing child. Seafood, like I said, has the organic arsenic type and is less toxic. Tobacco smoke might be contaminated with arsenic. Arsenic pesticides in food, such as wine, industrial areas, smelters, which is, you know, occupational hazard, landfills and waste. Wood treated with arsenic preservative, especially wood treated in like playgrounds. You want to think like, you know, if a child has high levels of arsenic, you know, you want to ask mom, where's the playground? Is it wood, right? Is it made out of wood? And has that wood been treated with arsenic? Something you want to think about as, you know, one of your differentials or one of your causes for high levels of arsenic in a child. And some household detergent, Woodlight, if you go to the EWG website, Woodlight came up as, you know, toxic for arsenic. All right, so arsenic and cardiovascular disease, there's a study there, I put the PubMed ID. So arsenic reduces nitric oxide by inhibiting endothelial nitric oxide synthase. It also increases oxidative stress, causing tissue damage. We know this. It can upregulate pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin-1, vascular cell adhesion molecules, and VEGF. It can induce atherosclerosis and is also pro-arrhythmic. So a patient who has high blood pressure, you know, just don't assume that it's lifestyle, familial, hereditary, genetic. You probably also want to look at their toxic load. Sorry, there we go. So arsenic clinical manifestations. Clinically, with true arsenic toxicity, you're gonna start presenting symptoms within the 2 to 8 week mark. Hyperpigmentation is one sign. Black foot disease, you can Google the picture, is classical for arsenic toxicity. Hyperkeratosis, so corn-like elevation, specifically in the palms of the hands and the soles of the feet. GI disturbances such as nausea, vomiting, diarrhea, and abdominal pain. Mees lines, which are these horizontal lines that tend to pop up again around the 2 to 8 week mark. If you see a patient with Mees lines, you know, suspect potentially arsenic exposure. Stomatitis, garlic breath, again, very specific for arsenic. Hypertension and myocarditis and pericarditis, you can refer back to the previous slide. And very severe high cases, blindness, deafness. Peripheral neuropathy is another huge one for arsenic. So patients with peripheral neuropathy, you want to run a toxic element panel and make sure you're following up on that. and cancers, right? Bladder, lung, skin, kidney, and prostate. Arsenic Labs. So there are many ways that you can test arsenic, either through the hair, blood, serum, nails, or urine. I like to run environmental toxin panels, which we'll talk about them in the end, and you can actually get it both in the blood and in the urine. Hair analysis is actually very specific for arsenic. So I know with hair analysis, it's a little iffy. Do we trust it? Do we not? But when it comes to arsenic, it tends to be a really good lab marker because arsenic has a high affinity for the keratin cysteine residues. So high levels of arsenic in a hair sample probably does indicate a true arsenic, toxicity within systemically. You might want to check drinking water, test the waters, and test locally to see, is this patient being exposed to arsenic locally? Methylation panel and methylation snips, so homocysteine, RBC, folate, serum B12, methylmalonic acid, as well as your typical genetic methylation snips, MTHFR, MTR, MTRR, etc. Because arsenic has an ability to not only mess with the mitochondria, but reduce methylation and kind of impair methylation in certain individuals, especially those who are prone. You want to check glutathione markers and its SNPs, GSTM1, GSTP1. I'll share a lab at the end where I like to test these genetic SNPs because if they have these SNPs and they have an inability to properly make glutathione, adequate levels of glutathione, things like arsenic is going to build up over time. And then oxidative markers and DNA damage, 8-OHDG is a good marker for that. So for patients with arsenic, you definitely want to support methylation, methylfolate, methyl B12, B complex, choline, magnesium, right, for that ATP. Alpha lipoic acid for patients with peripheral neuropathy. Selenium as an antagonist, vitamin E and zinc, proteins that are, choline and methionine, which are great methylation factors, NAC and glutathione as well. So here are my references. Cadmium. So the main tissue target for cadmium is the kidneys. And one way of exposure is orally, right? Through food, through water. However, there's a low GI tract bioavailability for cadmium. Cadmium inhibits glutathione reductase. It also inhibits other antioxidant enzymes such as catalase, manganese superoxide dismutase, copper zinc dismutase. So you're thinking about patients, right? Who are we thinking? Parkinson's, Alzheimer's disease, patients with neurological, neurodegenerative diseases that need good antioxidant supports from these enzymes like catalase, manganese superoxide dismutase, etc. You're thinking cadmium, you're thinking toxic elements, so you want to follow up on that. Cadmium is mostly excreted via the stool and urine. Urine it's most favorable. So cadmium exposure, you can be exposed to cadmium via tobacco smoke, drinking water, nickel batteries is a huge one, zinc and lead smelting, paint pigments, red, orange, and yellows, right? So if, you want to think about that, right? Especially painters, right? Or maybe someone recently painted a nursery, you want to make sure, what type of pigments that they use and could it have some cadmium traces, right? Galvanizing plumbing, oysters, kidney and liver food, and also canned evaporated milk and infant formula. So with cadmium exposure is mostly asymptomatic. What you might find clinically is that you run a fasting CMP and you notice a trend in the patient that their EGFR is coming down, creatinine levels are rising, and there really is no known explanation. They might not be hypertensive. So you're like, what could be causing damage to the kidneys? Think about cadmium. Proteinuria may be present in patients with cadmium toxicity. Osteoporosis may also be evident, hypercalciuria and kidney stones because that inability to kind of regulate calcium levels due to the high turnover of, you know, bone loss. Polyuria nocturia, less common, but it can be a clinical finding. And then cadmium nephrotoxicity. So, like I said, it has a great affinity for the kidneys. So, patients with early stages of chronic kidney disease, you want to think cadmium and ruling that out as a possibility of exposure. So, there are three major clinical manifestations with cadmium. Kidney disease, I already talked about that, right? Most common proteinuria, right? So, if their eGFR is dropping, they have proteinuria, maybe they have hypercalcium, right, in the urine or in general, you want to think cadmium. Bone disease, osteoporosis, osteomalacia, fractures. So one common theme across all metals is osteoporosis and neurodegenerative diseases. So just as like something to think about clinically. Cadmium potentially lowers the conversion of calcidiol to calcitriol, which then reduces calcium absorption. And that's kind of the mechanism of that. Pulmonary cancer, so zinc smelters are at great risk for this. And then it can cause COPD, emphysema, and obviously lung cancer if not addressed. So some lab markers for cadmium, 24-hour urinary cadmium with normal creatinine function, right? So it's actually a pretty good indication that there's true, or at least acute or subacute exposure to cadmium. Stool, not that common. Blood with acute exposures only is a great test for cadmium. Hair, not as accurate as arsenic, because cadmium does not have great affinity to the hair. And then there's urinary beta-2 macroglobulin, which not really done clinically, but sometimes when you come across literature, they might use this marker, or if there's a huge suspicion that there's like true acute cadmium toxicity, this might be a marker that they run. So what are diagnostic criteria? Increased blood cadmium, urine cadmium, and also increased urinary beta-2 macroglobulin greater than 0.3 milligrams per gram. These are per OSHA standards. So OSHA actually, for like zinc smelters, for example, they kind of keep track, make sure, and they kind of follow up on these patients to make sure that they're not being too exposed to cadmium. And if so, then they get pulled out of work. And then there's this whole thing that you can look at up to date on how they follow up with those individuals. There are other markers that might be elevated with cadmium toxicity, urine NAG, and also elevated kidney injury molecule 1. These are most commonly used for research purposes only and not so much clinically, but I think you should be aware of them. Cadmium management. The best thing you should do for cadmium management is prevention, because once you have that toxicity within you, there's no standard treatment as of now to kind of pull that cadmium out. Quit smoking, obviously, because tobacco smoke could be laced with cadmium. You want to follow OSHA guidelines. Dialysis might be necessary for patients with chronic kidney disease. High dose vitamin D, because cadmium can predispose patients to osteomalacia or osteoporosis. You want to replace the zinc and the selenium, which is a very common trend within toxic elements to kind of lower these two essential elements. You want to do methylation support, NAC, glutathione, and there's some research on lactobacillus and bacillus cereus that kind of help, especially cadmium that comes in orate, kind of helps detox and remove the cadmium as waste. Now let's move on to lead. So before the 1980s, lead was commonly found in gasoline. Before 1972, there was lead paint. However, lead paint continues to be a problem in older homes that haven't been remodeled, or they might just not be aware that the paint that was used at that time has lead. And this is obviously a very common sight for children to kind of chip the paint off and get, lead toxicity. And then lead gasoline, although it hasn't been used since the 1980s, there's some suspicion that it's still, within the highways and still very heavily polluted. Lead pipes obviously leaches in the local water supply. So old lead pipes that haven't been updated, contaminated soil, remodeling old homes is a huge exposure, right? It's highly transmissible via breast milk. Herbal medications imported from China and from India, you have to be careful, might be contaminated with lead. Some calcium supplements, although if you're using a reputable source, it's not an issue. And then the target tissues for lead is the bone and red blood cells. However, it can target any tissue as well. Absorption mostly orally. So mostly oral absorbed by iron transport divalent metal transporter 1 in the GI tract. So what does this mean? Let me explain. So patients who chronically have iron deficiency anemia, iron can be absorbed in the gut via this DMT1. When iron levels are lower, there's an upregulation of DMT1. DMT1 also pulls in lead from the gut. So in theory, right, by correcting anemia, you might be able to lower an individual's chance from absorbing lead in the gut. So where can an individual be exposed to lead? Makeup, such as lipstick, especially if it's imported from overseas, lead paints from old homes, water from lead pipes, contaminated soil, organ meats, especially in the liver, and tobacco. So heme synthesis inhibition, I think we're all aware of this, that lead kind of increases, it binds to, it displaces basically the last couple of steps in heme synthesis production. So you might want to test for increased urinary corpuscles and increased urinary erythrocyte protoporphyrin levels in the urine. Specifically inhibits these two enzymes, the ALAD as well as ferrochelate enzyme. You want to assess for lead-induced anemia in children because of kind of the mechanism that I explained in the previous slide. And also that DMT1 in adults, it does increase lead absorption, but in kids, it's like a 50% increase in lead absorption via the gut. So they're at much higher risk for toxicity of lead than an adult that's exposed to lead orally. Some lab markers saying protoporphyrin because it can just, it's a good marker for lead. Lead can be measured in the urine, in the blood, capillary per OSHA standards, hairs and nails. The gold standard for this, per the CBC, their numbers is adults greater than 20 micrograms per deciliter is considered lead toxicity. Children greater than 10 micrograms per deciliter. So what is the management? Prevention, right? If you purchase an old home, you want to make sure that it doesn't have lead paint. And if it does, you have to get professional individuals to come in and kind of tear down some of that lead, to tear down and remove it properly. So home inspection is very important. And you want to act promptly. Lead is not, it's very serious. And IV EDTA remains obviously the gold standards for acute cases, especially for children. And you want to replenish at the same time other essential elements like magnesium, calcium, and iron that are, is usually lowered with lead. B complex for both blood building support. Zinc, selenium is also of benefit, as well as NAC and glutathione. And then there's mercury, right? Wall neurotoxin, teratogenic, commonly found in dental amalgams. So if it's not on your intake form, it should be, right? We need to ask all our patients, do you have dental amalgams? How much? How long? And because that's a chronic exposure to mercury. Target tissue, the nervous system easily passes, some of the forms easily pass through the blood-brain barrier. Fetuses, infants are extra susceptible, and kidneys. So here's a breakdown. You want to know the type of mercury, the dose, the age. Is this an acute mercury exposure, chronic mercury exposure, and the route of contamination? So let's talk about the mercury types. There's elemental mercury, which is less toxic. That's what's commonly found in dental amalgams, air pollutions, and your old school thermostats. The common toxic forms are the organic type, and that's usually ethyl mercury and methyl mercury. Ethyl mercury is what we find in thimerosal, and thimerosal is what we used to find in vaccine, except there is some thimerosal in some of the current flu vaccines. It depends on the flu vaccine. And then there's methyl mercury, which is usually found in marine life, and it's the most toxic. It's highly water soluble, so it's easy to kind of spread in our seas and contaminate our fishes. So that's organic type. Then there's the inorganic mercury. Examples are used as preservatives in medication, creams, eye drops, and ointments. Chronic mercury toxicity, for example, in dental amalgams are less obvious and they're often missed. That's why we constantly have to ask patients, about their dental amalgams. I'm sure many of you guys are already doing that. And then age matters, right? Fetuses, infants, children, they're extra susceptible to neurotoxic effects of mercury because it easily crosses their very underdeveloped blood-brain barrier. The root, it can be injected. If it's injected or inhaled, it's the more toxic versus consuming it via food. Mercury exposure, obviously fish, the bigger the fish, the higher potential there is more mercury in that fish. Electrical wiring, so your electricians, you want to ask, they're probably being exposed, constantly touching the mercury. Dental amalgams, smelting, coal mining, and just overall fossil fuel. So what labs do you want to run? Acute blood mercury levels. Blood mercury levels if it's acute, and if it's chronic, you might want to do a 24-hour urine mercury level, or at least the first morning urine, and also an environmental toxin panel. Obviously, prevention is key for all of these elements. You want to eat fish in moderation, know where you're getting it from, and try to stick to fishes that are low in mercury, like sardines, perhaps some wild-caught salmon, shrimp, etc. You want to offer antioxidant support to offset some of that oxidative stress. So N-glutathione, alpha-lipoic acid. You want them to remove their amalgams by a biological dentist who has a proper equipment and proper training in removing dental amalgams. Selenium and chelation therapy when, is at toxic levels. So some additional information, additional support, there's the EWG, Dirty Dozen, Dirty Clean 15. Like I said, sometimes you can find some toxic elements in pesticides. So you want to, gear towards the Clean 15, do organic for the Dirty Dozen. Noting importance of locally grown goods, USDA organic labels, etc. If you are part of the IFN family, they very generously provide a toxin exposure questionnaire in the toolkit. I think it's a great questionnaire and we use it all of the time to kind of gauge if it's not that clear that this patient might be, at risk for toxic metal toxicity. There's your questionnaire. IFM also has a handout that's patient friendly where it discusses reducing exposures to harmful chemicals, Sandy Hook Clinic methylation diet support with Dr. Kara Fitzgerald, which she'll be releasing her book very shortly because a lot of these need mitochondrial support. It needs methylation support to be able to properly detox the metals from the body. Or IFM also has a detox food plan, and you can always go to the ewg.org website for more information about just everything toxin related. Then I want to talk about sauna, give it a quick shout out. So here's a systematic review with arsenic, cadmium, lead, and mercury coming out through the sweat. So it doesn't have to be, doesn't have to be a specific sauna. Any sauna is better than no sauna. And exercise, obviously, exercise is a way to kind of clear the emunctories, get some of this heavy metal toxicity out. What's pretty interesting is that if you don't have a sauna, going to like, let's say your local gym sauna would be a great idea, but that does expose you to other people's toxins as well. So if you have an at-home sauna, technically that's more favorable. So here are some functional lab that we use to assess environmental toxicity, and some of my favorites that we order very regularly. Genova Diagnostic has a nutrient and toxic element, where it's a whole blood profile, and it's looking at aluminum, arsenic, cadmium, lead, and mercury. So all of the elements that I just talked about. In addition, it looks at calcium, copper, potassium, selenium, and zinc. We talked about the importance of selenium, zinc, calcium. All of these things are very important because one way or another, these elements are kind of messing with these nutrients. So you not only want to look at the toxic load, you also want to look at what is it doing from a nutritional standpoint, and correcting that where it needs correcting. ZRT Labs also has a heavy metal and essential element test kit, which they only test for cadmium and mercury, from my understanding. However, they do a zinc to copper ratio, selenium, magnesium, and they also do urine iodine, which is a really nice plus to have. Then there's US Biotech Laboratories. These are for the other environmental toxicities, right? Benzenes, phthalates, parabens, which we didn't have time to discuss today. But if a person has heavy metal or just metal toxicity, they probably are exposed to other environmental toxins as well. So pairing the two will give you a better full clinical picture. Then there's a Vibrant Wellness, which is is similar to the US Biotech. They're both extremely great labs and extremely comprehensive. So I kind of put the link here to check them out. The Great Plains Laboratory. What's really cool is that they offer a glyphosate test from the urine, but you can also send in your water to sample if there's any glyphosates in your water, perhaps cross-contamination. So this is a nice handy tool for patients who you suspect high levels of glyphosate, and and you should check their water source, and it's cool that they offer this. The Great Plains Laboratory also has their Mycotoxin profile, which we order a lot, and it's really comprehensive. It's cost effective for the individual, and it's a great way to look at mycotoxins as another form of environmental toxicity and exposure. Genova Diagnostic has a NutriEval. Amazing, great test. It's a very good comprehensive look at essential elements. It does contain, I believe, like lead, manganese, like so many different nutrients and elements that may or may not be essential. And it also contains a fatty acid profile and an amino acid profile. So it's as good as it gets if you want the whole clinical picture in one test. And then there's this one test from Genova. It's called the Toxigenomic Profile. So it looks at various different SNPs, but as well as genetic SNPs in glutathione, NAC, and superoxide dismutase. Obviously, this is a great test for anyone who you are suspecting that has impaired detoxification, and perhaps you kind of want to take it to the next step and kind of like prove it and see like where in the detox pathway they need support. Patients with ALS, patients with neurodegenerative disease like Parkinson's, Alzheimer's disease, I think it's absolutely necessary that a panel like the Toxigenomic Profile is ordered to kind of get the full clinical picture of what's going on. So now we're going to switch gears and talk about mycotoxins. So mycotoxins are toxins made by mold. And there's different types of mold, and each type of mold creates its own toxin. And those toxins go into our bodies, and they kind of create very ubiquitous symptoms. It's not very obvious, and if you're not taking a good detailed history, you might just miss it. So with mycotoxin, what you're thinking is fatigue, number one, brain fog, myalgia, weakness is very clinical, like very pathognomonic. But with fatigue, right, you're thinking also, oh, maybe it's anemia. So if you ruled out everything else, you might want to look at mold. Headaches that are constant, shortness of breath, cough, wheezing, GI distress. Sometimes dermatological issues can appear with mycotoxins. Patients who are extremely overly sensitive, even to homeopathics, you want to think, maybe I should run a mold panel. Worse with certain seasons, especially like the fall season, which mold tends to be higher. If they recently located to a new job or a new home, perhaps there's mold growing in that space. If they live near a construction site, if it was triggered by an event, perhaps they were spring cleaning and now they have all of these symptoms that they've never had before, like brain fog, itchy skin, etc. And obviously home remodeling. So Zia's from the Fusarium mold family, and it's a mycotoxin. And the reason I wanted to give it a special shout out and add it to this presentation is because it's a xenoestrogen. Now, I would say there's an epidemic, or a small epidemic at least, of women coming in with either endometriosis, PCOS, and ovulation, so many things, right? I think we're all seeing it to a certain degree in our clinical practice. And we're running tests like the Dutch test, which is a beautiful test, right? It shows levels of estrogen, progesterone, perhaps testosterone dominance, estrogen dominance, etc. Lack of methylation. However, when you take a clinical history, you're like, where's the estrogen coming from? Maybe they don't quite fit the PCOS picture. In this case, right, I'm thinking patients with uterine fibroids, right? Because fibroids tend to, be stimulated, the growth is stimulated with estrogen, right? Estrogen binding to the fiber, allowing it to grow. So you're thinking, oh, estrogen dominance. But then what happens when your Dutch comes back and there's no estrogen dominance? They have a beautiful, follicular phase, luteal phase, estrogen, right? So then what, right? Look for Zia. Look for this mycotoxin because it is a powerful xenoestrogen, even more powerful than your isoflavones like soy products. Okay. And so the structure resembles 17 beta estradiol, which allows it to bind to estrogen receptors. It's a known endocrine disruptor. It has a high affinity for female organ systems. Its main source of location is wheat, rice, corn, and contaminated water. So, talking to the patient that if they eat a lot of rice or a lot of wheat, depending on their cultural backgrounds, and they're a female who, either she has estrogen dominance or doesn't have estrogen dominance, but is showing estrogen dominance in a different way, like a growing fibroid, you want to think of this mycotoxin. There's a potential link with Zia with cervical cancer, ovarian cancer, and as well as prostate cancer in men. And its main pathway of excretion is via glucuronidation. So supporting glucuronidation with food, as well as supplement is a good idea with these individuals. And that takes me to the end of my presentation. I hope you guys got some insight on heavy metals. And yeah, thank you for having me.